Good morning and welcome to our monthly webcast. I am Samir Mehta, your moderator. This is session number 191. It's an absolutely beautiful spring morning in New York, and I hope all of you are blessed with fine weather wherever you are. Traditionally, it is our CTOs which bring out the biggest audience. We have selected an exceptional, probably a retrograde CTO in which you're going to learn all the basic and the advanced skills. With this brief introduction, let me take you to the Cardiac Catheterization Laboratory where Dr. Sharma and Dr. Kinney are standing by. Sameen, good morning. Is that your recollection also that it is the CTO which brings the biggest audience?
Yeah, so clearly the welcome to our CCC live viewers globally, and myself and Dr. Kini on my left side, and we are two fellows, Swati and Pratish. We have the biggest fellowship in the country. What you said is the retrograde. So I would say that there is a lot of interest on the retrograde CTO PCIs. We have done probably 4 or 5 cases over the years. So we have one of the largest audience on that when we do the retrograde cases, because we go through the step by step. Now, just to say, only case which has superseded all of our live cases is the LED diagonal bifurcation with the rota of both the branches and mini crush, which has over 70,000 hits. So taking that out, your rest of the statement is absolutely correct, that we get a retrograde CTO, 20,000, 25,000, every one of them. And the regular CTO get at least 28 to 30,000 viewers hit. So CTO still remain. Now question comes is, we teach so much calcific bifurcations, so that remains our forte. We did a Impala case, one last year and one this year. We did request about some more MCS cases. So once they are appropriate, we'll go for those MCS cases also. So the new request has been only for the MCS. And I know the CTO, particularly retrograde, has been a request few months ago. And we are here now to show another retrograde case. The last one was done 3 months ago and very successful. So now, you want to just show the live, right? Oh, okay.
Go.
Wow. Okay, so if we can go through our presentation. So let's go, because Dr. Kini is ready here. You go to LO view. LO is, we have a lot of collaterals, bridge collateral. That's what they tried. So this is the case. Remember, this angiogram is done almost 6-7 months later than the first time. So this is our live cases. Just want to tell everyone, our audience, the CME accreditation, which is that you have to go through the case in the end, just fill up the form. And it has not been a very, I would say, the enthusiastic activity. Why? Because we get 30, 40, 50 hits. So we are leaving it for 1 more month. And that is basically till next month. And here, unless we go to the 3 digits, I think it's not worth pursuing the CME accreditation, but we'll follow it. Target audience, the overview, learning objectives remain the same. Select the case and go step by step, wise approach, which we are going to show. And accreditation is 1.5 hour of CME through the CME solution and GAFNI events. Our operators, myself and Kini, nothing change, and moderator with Samir. Commercial support, we all have unchanged also. And then, as I said, in the end, people can just log in and get their 1.5 hours of CME credit. Now, as we said, case number 191, young person, 40-year-old. He had angina last year, had negative stress test, but because of angina, they did a cath, and RCA was total. They did try to open a little bit, but Antigrade, because of bridge collateral, left it. And good LV function, rest of the factors on the left side, as you can see, very well controlled. Good medical therapy, they keep adding. The things which it did not tolerate, amlodipine and ranolazine, which is part of the medical therapy. So after September, one vessel disease of the mid RCA, 100% with a JCTO score of 3, low syntax score. They tried to open the vessel, could not be, and then patients were referred to Anu for CTO Retrograde Approach. So Re-PCI of the CTO, that's our plan, and this patient will fit in despite negative stress test, but had the maximum medical therapy, so it will appropriate for intervention. So with that note, Anu, you want to show? Okay. Good. All right, show that now.
God, it's okay.
I mean, there's
That's our EF, which is
question
mildly decreased, and then this is our dual injection, okay, where you can see the first septal, which has bifurcation, but you see it well, and this is your the LAO.
Actually, that's interesting because we have the echo on this patient. A few months ago, EF was 55%. Here definitely looks a little down. But anyway, this is a collateral issue.
Okay, this is where we are.
Yeah.
So
The-
here is both. I'm modifying a question which came that a patient like this attempted at another institution. Would you still give it a antigrade approach possibility or proceed straight to a retrograde?
I think the previous intervention was done like within 4 weeks, and I did see the angiogram. So there were multiple channels created.
Yeah, play.
Though, if you see here, it does not look that way.
Right.
Okay, so the question is, what do you think? We should try, but we may get back into the same track that they have created. So I think he was referred for retrograde because they failed.
So we keep it that way. So coming back to the question, I'm sure that was the
now if somebody is asking you the question, even though they failed, can we try it? You want to try a little bit, okay, but then this is what happens. You will try one wire, then you'll think, you know what, let me try another wire. Okay, let me try the third wire. So it just committing, and then when you go retrograde, as long as you know you're in the lumen, you're good, but then you don't want to ruin the chances of success through the retrograde by creating dissection antigrade.
It's also in a way being disrespectful to somebody who's referred a case. You know, look,
that's true.
I've tried everything antigrade. I'm sending this patient back to you, and you are the retrograde specialist, and you go ahead and open it antigrade and call me, and I think that's the end of your referrals.
Yeah, and that's a very important point. And you know, that is how we have developed the referral practice here at Sinai, that almost 1/3 of the cases are referred by other interventionalists or advanced senior cardiologists who feel that some particular technique should be used, and we try to honor that. So I can tell you the case yesterday came to me, moderate calcium, LAD, and they felt, you know, like my guy, you know, my associate started doing the PTCA. I said, listen, there is no contraindication in this particular case to do a rotational atherectomy. Patient has been sent for calcific management, so I think it will not be good for us not to do rotational atherectomy. You want to do the IVL, that may be okay. But patient has been sent for, I know it was not a tram track severe calcium, but it was like moderate to severe. So we then changed it. So coming back to the point, it is very important, particularly if the senior cardiologist has sent you a case, and more so interventionalist. And if you do not follow it, that is the end of your subsequent referral. Yeah, Anu, tell us.
So now, so if you see here, question is, there are multiple, okay? Ideally, you need a straight connection. So if I go back here, I think, let's see. Not the first, see the fanning septal, right? The first is not connected, first branch. The second looks like is connected. So let's try that.
And what wire, what cath?
This is a regular fielder. I think we went through this few months back with all the various wires that we have. We can show
the long Corsair?
Yeah, 150. This is a Corsair 150, and Andrew can show some of those. You know, last time we had a discussion about why we should use SUO, right? Yeah.
Okay.
We can show those slides in the show me some die here.
Anu, so what app should people be looking at as they follow the procedure?
We have what is the guide wire.
Okay.
Some die there, yeah.
So this is very, very important for people observing. No wasting time. Straight away, the decision has been made to go retrograde. The
Yeah.
septal has been identified, and the support catheter is there.
Yeah.
Uh,
And the wire has crossed. You see that? Through the septal collaterals, the wire has gone into. You want to go to other view?
Yeah,
I mean,
I will. I just want to make sure. So
Yeah.
when you're, so you see how my finger movements are to get the guide of the left system.
And anytime you're advancing Corsair rotating this way, the guide will come out. So make sure that you're holding the guide.
This is always an, when you are reaching the septal closer to the contralateral vessel, you know, near the base of the septum, you have this issue.
so for our audience, here is the guide wire aid app. Sameen, I have probably opened the Pandora's box here by mentioning about how to treat referrals and expertise of referrals, and so many emails and text messages have come pouring.
Yeah.
That and one of the smarter ones, again, the answer is by Nikhil Jha, not a surprise to us, a very regular follower, that he always insists on getting the CD and reviewing it carefully, which I think is your practice too.
Has to be. And we tell all our fellows, international fellows, that before you go in the room, even 1 minute, you have to review the case with attending with your strategy.
It's
And
not
of course-
not 1 minute.
Okay,
It's
2
a
minutes.
Yeah, no, more than that.
Yeah.
Don't
3 minutes.
underestimate.
Yeah. But key is that review the case with attending. Now things may change. That's a different story. But you have to review the case before going in, particularly when the CD is, angiogram is there. Now many times nowadays, we don't get the CD, but we have on the WhatsApp or on text the entire video. So whatever it is, but you check it there. These are all, you know, very the security chat, the communication. But key is that usually, or I would say 80% we get the CD, but other 20% some other ways are available to take care of that. Yeah. Tell us now.
No, more important, we have a board round. We start at 6:50 in the morning, sometime goes 7:20, 7:30, discussing every single case.
Yeah.
I know
Every
I
single
can,
case.
I can tell you after watching it many times, that is possibly the best educational component of the fellowship.
Yeah.
I mean, not only are they understanding the case they'll be doing, but a review of just about everything. So I'm pretty sure very beneficial. Another question has come, could this be tried radial?
Well, I would say for radial gurus, nothing wrong in that. A lot of people will do bilateral radial. And the only thing is that after the case is done, if it is long, they have to book the massage. The spa and the massage is special. No matter how your hand is. Yeah.
And the massive radiation exposure.
And massive radiation exposure. Yeah. And as you know, that
Both the
actually
patient
particularly,
and the-
yeah. And the physician actually in India, now in last 1.5 year, I have learned 3 interventionalists getting some kind of a brain tumor or brain cancer. And one of them, people might know, is in the very
Miracle
end stage.
6.
So trouble is always trouble. And so that's why people start using in India more the skull, the head caps with the radiation cap. We don't use it here, but maybe we should start using it. But we don't use here because here is also everything is very guarded, everything followed. And if you really have done too much radiation, we get the report every month that you had to be out of the room. You cannot be doing the radiation. I mean, continued procedure. So we alter, we change things. I know that kind of strict follow-up may not be available in India, and many centers, many of them, yes. But this radiation is a very big thing. And
Yeah, Samir, what we probably need to do is one day do how how we can do this kind of complex procedures in a kosher way. For radiation, I mean, if you can ask the fellows, you'll know the one person that really teaches them how to do entire procedure safely using all the radiation metrics.
Okay.
You
And
see
what I
now,
do
as soon as I look at where this shield is, completely protecting me.
Yeah, yeah, no, not only that, Anu. I think
And I'm not on the floor.
you both Samin and you very intelligently use collimation, which is something which
No,
people
no, no. Only I use
I may
collimation.
not be in that
No,
category.
No.
but-
Only I use collimation. Yes.
But our is the single view. So we will do just whole case with a single view, and that's it. Now the question is, tell us, Anu, you change the wire now.
Yeah. Now, so we are. I change. I try to do it with a fielder, but if you see that, it's keep going to the what I say. That is that branch, mega RV branch. You see that? So this fielder keeps going there. So I took a Miracle 6, some dye antigrade.
Antigrade, yeah.
It keeps going that side. So we may need a little stiffer wire to.
And that's your Miracle 6. Next one will be what?
Depending on how this behaves, how stiff I need.
Your little dye antigrade, right? Looking good. And then, the radiation red power, that shield, which they are putting on the patient's
Some dye.
chest wall and all those things. So all those things help to decrease the radiation further. And most importantly, the newer machines. Our newer X-ray machines are very, very good. So their radiation, so we have actually one room, which is room 1, which is, for 10, 11 years old. That was the best one at that time. Their radiation is almost for the same time period, same people doing it almost 2.5 times.
Okay, good.
But things
in
have
the
changed. Yeah.
meantime, Anu, this is just amazing skills, and I mean, you made it look all so simple. I mean, this is a superb job with the wire here.
So
And this
now
one,
we'll try to get this across.
Yeah.
Miracle 6.
Yes. We need it soft. See now how the guide is not. So here, what the best thing to do is get me a 2512. Let's anchor this wire. Yeah. And then
Anu, a lot of people congratulating you here.
thank you.
Yeah.
Excellent job. Hats off. Samin, there's a very pertinent question. I'm going to read it exactly as it is. Dr. Mahmood El Rais.
Yes.
What is your view regarding putting wire in the aorta through left guiding to prevent ostial left main dissection or deep engagement?
Yeah, so that will be the
No, they want a wire
yeah,
here.
I know, exactly.
That will be.
So I think you have a lot of people, key is no matter what you do, when you are manipulating this, your guide catheter will go in and out. Even you have a wire, guide will take with a wire.
Yeah.
I can tell you that about 10, 12 years ago, we have one of the Japanese colleagues who came, actually not 10, almost 14 years. And they put the wire there. So what happened is guide catheter went in, knuckling the wire and caused the left main dissection right here in our cath lab.
What's this side? Yeah. No.
We
It
have
has
to go
to
to
be
the
here on the
antigrade.
RCA. I went on the.
Yeah. You have to go into the RCA antigrade.
RCA
Yeah. So
antigrade.
we are now stabilizing this wire or anchoring the wire so that now Corsair can go. So make sure Corsair's length is 150. Other one is 135? No, I know,
Okay,
but
yeah,
what is
good.
the other size? Yeah, that's what I'm saying.
Good.
The not a 135. So you need a longer.
Yeah. If somebody uses turnpike, then what's the turnpike? Yes.
Turnpike is also long.
Yes. They are 150. Yeah.
150, yeah. So you need a 150. So now we are anchoring the balloon. You see that in the guide. The pressure will disappear. Yep, good. And now you can advance.
So the.
You see that guide is still going in left, but as long as you are careful, that is perfectly fine. It is just reaching there.
Just an outstanding job.
Yeah. Good.
Okay, now we can.
Deflate. Right?
You know what? I want to go a little bit further up.
Yeah, pull back the balloon then.
Yeah.
You have to pull
Okay,
the balloon back.
Go up again.
Yeah. Yeah. Now go. Yeah. Good.
Okay.
That's it already.
Deflate. Now we can remove this.
Yeah.
Right.
So now question will come that how do you exteriorize, which I have emphasized, last time step by step, and now which wire you are going to use? What are the exteriorizing wires? There are
Can you
3 of
show
them.
those slide of all the RG3s? We went through this also last time.
Yep. Just once again.
Which one are we using today? 3? Okay.
Yeah. So these are the one R350, RG3, Viper
So if you
wire.
see how to remember, 350 means the length is 350 there. RG3, everything is 333, right? 3 gram tip, 300. And the dark portion is 3 centimeters. Then you have your Viper, and then you have a rota extra support. We said if you don't carry any of these first 3, no, first 2 are the best. If you don't carry, you can use the Viper, or if not, that also don't exist, maybe you can use the rota extra support wire.
Okay. I mean, I will be a little concerned about the rota extra support because it may not give you enough strength, but now since you already crossed, knowing the retrograde tip is much easier, should not be the issue. I always worry about the rota. A lot of people do rest of the PCI after rota on the rota wire, cut it and make it a monorail and make it. Only problem is very flimsy wire. It just gets bent very commonly, and so we try as such not using rota. Viper is good. Viper wire is 0.012 compared to rota 0.009. So that has been an issue. But yes, the key is the Viper wire. Most of people will have a Viper wire. So that is something which can be used without any problem. And particularly the Viper peripheral is 0.014 and the corner is 0.012. So many people have a peripheral Viper wire which can very well fit in. Only thing, it will not take the orbital atherectomy, coronary orbital atherectomy, but can be put for this purpose. So tell us what you are doing now.
So now this RG3 wire is coming out.
So RG3 wire is being advanced.
So we are went through the left side.
Yeah.
It will go through the septal. I'm trying to see if I can see it.
It's still coming. And it went quite a bit. You came out.
It's coming out. Huh? You think so?
Yeah. You see it, you have to see it below. And you need a needle.
Yes, we have a needle.
Okay, good.
Yeah, we have the needle introduced. Hold on.
Finished?
Okay,
Came out, yeah.
came out, yeah.
I mean, another
Yeah.
question for you. Sometimes do you do a CTA before accepting complex CTOs?
Yeah, so very good point. So a lot of people do in terms of the course, and so we are not a big believer of that. And we are never done it. The other people, some people will use the imaging, IVUS guidance. There are some data plus minus. Some people are big believer of the IVUS, but we have not been that taking the. There are papers about that doing a CTO increase the success of your CTO recanalization because giving you some idea which you cannot see even by retrograde injection. But I think something which, let's say, is available online in the cath lab, then only it will make sense. But if you have it just done it and you not have active participation of that CT, I don't think it will be of big value. But yes, we'll give you some idea. We actually had a case almost 8-10 years ago. We could not open that circumflex. We did the CTA, then we brought the patient back. With the CTA also knew what the pathway would be. But we did not succeed. So we went back. So with only one case I remember where I used a CTA to guide the Re-PCI of the failed CTO, and that is still failed. Anu, you have done any CTAs for the CTO workup? No. So we are the same. Okay, now there is a wire has come out, and what is the step now?
Can you
Yeah, they're
Show
seeing
the
it.
camera because I
No,
keep
they're
doing
showing it.
here.
No, they're showing it on the camera. Going
Yeah,
on.
but they're not, you can't see it enough.
No, but then take away the pictures, your slides out now. Let's show the hands movement a little more.
It's too bad.
So magnify that because that's more important. The slides have been shown now. Good. Here. So show it what it is now.
Now I'm going to remove the, now you see the guide is getting sucked into the left
Yeah.
side.
Yeah.
This is where the biggest question comes. I'm going to hold the guide a little bit.
Okay, let's leave it there. Let's go antigrade, dilate, and then let's get the guide.
Yeah.
Then we can remove this. Yeah.
Okay.
And
Good.
the length of the RG3 is 300 or 330?
RG3 is 300.
330.
330.
330.
Yeah, 330. What size is this? Went in? Okay, let's
2.5
just,
balloon is okay.
okay, let's see.
So now we are going anti-grade. You see the wire came out and going cut the tip of the wire, which is floppy, and then you advancing the.
Give me
balloon.
not 300, 150 run through.
Yeah, you can take a run through now, anti-grade.
Okay, good.
Yeah.
Dilate here. Once you have dilated, we antigrade run through, and that's, we can remove this
should do it,
later.
yeah.
Yeah. Okay, good. Down.
You probably need to go a little bit more.
We are doing a little different. Why? Right? Okay, down.
And a little distal.
Huh?
Little distal, no?
No, we are
Yeah, here,
good.
at this
No,
level.
no,
yeah.
no.
You're going to stand that area anyway, yeah.
Okay, down.
We can take a little bit of picture and see.
Okay. We'll go. No, 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 no.
There's the
Dilate
proximal
here.
lesion also, yeah.
Okay, down.
We can take a
Go up here.
Then 3048. Synergy or Zines? No, slowly.
Down.
Yeah,
This-
so anytime the watermelon sheet affects with these balloons,
Go.
so go slow. 2 atmosphere.
Go.
Slow technique, you can put a wire side by side. Then 4. No, moves. Okay, I think come back in the guide and see.
Okay, some die.
Yeah. Let's,
Okay, wait, let's take a scene. Antigrade, right? Okay, good.
Yep, that's fine.
Okay.
Yeah.
Give me the antigrade run through, we'll dilate. The thing is, I think we'll leave this alone.
No, put everything.
No, no, no.
Yeah. There is a tight lesion there.
Okay,
How
we'll
can
IVUS,
you-
okay?
Sure.
How can
The
get the IVUS
key
ready
is
also?
waiting.
No, but there is a disease there. Bad disease here. There.
No,
You
I
have to-
think the wire is doing all that.
Okay.
Okay, give me antigrade and then we'll remove this wire. We have to show how to remove this wire. Okay. We normally like to do is use a fine cross antigrade, right? Which we did not do. Last time we showed.
Yeah.
You go with the fine cross in the antigrade and you kiss the two and then you remove the wire.
Yeah.
Give me the, you have a fine cross? Okay, let's do that.
Yeah.
This is, now we have the RG across, you know,
An
The-
observation
yeah.
here, which I was too busy
mm,
answering the text. Is there an osteal dissection?
of RCA.
Just I didn't observe it quite
Yeah.
frankly, but
RCA?
no,
I don't know, RCA,
Remember,
that's just
there
a
was
disease.
lesion. The proximal RCA always have the lesion. Let me take you there.
yeah, but the ostium looked okay.
Yeah. So, yeah, see, there's a disease right there.
No problem. Okay, go all the way down. Now get us a run through wire also. No, not 150. Okay, you know what? We can do 150 here.
Yeah, we can do one.
Oh, it's yeah, 130. Okay, hold. Okay, good. So this is a safe way of removing this RG wire. You see, this is the fine cross. You see that? all the way.
Anu from Dr. Jha.
Mhm.
Safety wire in LED.
Yeah. Yeah. I don't think we need a wire in the LED. So you see that the fine cross all the way there. I will start removing the RG3 from this side. Okay. So
I mean, a lot of, the exactly same case in an older person with more calcification would have been a altogether different ballgame.
Different, yeah, absolutely. Calcium is the biggest, particularly with the CTO for enemy. Yeah.
oh,
I mean, other.
Oh,
that one, you see that was an issue.
So that's
there.
what
Let's
they
take
wanted, a safety wire there. But anyway.
No, that's not the thing. I think
Yeah.
this came out. We'll
Then-
take a picture of the LED. No, safety wire.
Yeah, so it means you have a wire in the LED all the time. That's what it means.
Yeah, too many wires.
Yeah. But put one wire in the fine cross. So, but doesn't matter. Now you go side by side. Yeah.
I mean, unfractionated heparin.
Yeah. Good.
Okay, so LED left main, everything looks good. We'll just remove this guide.
Yeah.
And I will use usually you need a 300 run through if you want. You go
No, but
through
we can
fine
do
cross,
this.
but this one, since we dilated, we
Yeah.
can go side by side.
No. Go through this. We'll show people how to take out the fine cross. Go outside.
Hey,
Put this one. I'll tell you. No, go inside. Yeah. No balloon. We show the new hydrostatic technique. Yeah. You know, that die is okay. So
IVUS
now-
is ready.
Yeah. So just to share that, because I can tell you Cardiac Cath wires are not available in India that freely, so that's okay. You don't need it, and we'll show you this, particularly the wire going through. This is our Corsair. No, this is a fine cross actually. Yeah. So what you do is see this now. We're showing it. Still show the top because you're more. Once you're there, yeah, here. So question is, you go forward.
oh.
Good. Keep going up. Fluoro.
So the balloon is
No.
anchoring you.
No,
to
no balloon. 1 second. Why did this
see
happen?
inflating there.
Yeah, just the indiflator to the to our fine cross. Yeah, and it will come out. Done. So single wire, just fine cross, you inflate and it comes out.
It's Nanto technique, right?
Huh?
Japanese doctor, Nanto
Yeah.
technique.
Yep.
Yeah, the chance of unsuccessfulness is 20 to 30%. You want to do it? Do it.
Okay. Now let's get it now. What is IVUS or stent? What do you want to do?
I don't know. You have key there. You have to get
But
keys
IVUS
input. Keys input.
Okay.
Okay, let's do a quick IVUS.
Yeah, this used to be called Novotny technique. We used to do it in the past. Then became the trapper. Then now we use side by side balloon. So a lot of money has been spent on this, how to take the monorail wire out, or monorail, or over the wire system with the single length wire. I would not do it for the stiff wires. That's the only issue remains.
Okay, this is
Okay,
the
we'll check
digital RCA. What
Sure.
are you doing?
And now the guide is out, so we can check the OCR also. Okay, we start forward. It's a distal RCA. It's coming. Huge vessel. There's also a lot of plaque. Yeah, so lesion. Yeah, looks like the catheter is in 2 lumen. Or 2 lumen. Yeah, disrupted plaque.
Everywhere is true lumen.
Yes, 2 lumen. It's all 2 lumen. The huge vessel. Yeah, it's
Good.
into the guide.
Nice. Okay.
Yep.
So the distal,
Do you want
I
dilate
think
the
I would put
3030 first?
148 and leave it.
You want to do a dilate first with the 3030, or we just go with the stent now?
I think
We can do the stent now and then post dilate, right?
Mhm.
Yeah,
The length is quite long. It will be at least 60 millimeter. What you have in your fancy stuff?
I would still think a 48 from proximal to mid is what we cover.
Yeah, the osteo RCA to the mid, like a normal landing zone, it's gonna be 50 or yeah, it's like 48.3 millimeter. And okay, so osteo RCA. So
Ostium is good.
there's some plaque,
yeah,
so
we'll
but
leave that
looks
alone.
like no clear like hematoma dissection. It's not dissection, but there's some like a 30% plaque at the
Yep.
osteo RCA.
Right.
But lumen is open, wide open, like area is like 8.
So we don't need to come up to the ostium. I think if we put 148 based on the EYE IVUS, we are good.
Yeah.
Now don't go to the distal. Now if you go all the way to the distal,
Yeah,
No, but there is a tight lesion in distal.
it's true. So there's some like area is like less than 4,
Look at
like a 2.8. This is a distal
to 2.8.
RCA.
There is a, right there.
Yeah,
Yeah.
so this is a distal RCA
Yeah.
lesion.
Yeah, 3.3. No, you have to cover that lesion, no question. Get a 48. We'll see whether we can stretch it. Yeah.
no. 48 is a prox to mid RCA. That's it. Then if you need something distally, you want to give some more nitro, take a
That's
picture.
a big vessel.
Oh, you mean 3O?
Yeah, start with there. But nitro, give little vasodilators. You have to do. Yeah, some vessel.
Rehabilitate the vessel.
Rehabilitate. Always before deciding about the stent, make sure you are given little nitro.
You want to
Vessel has gotten
okay.
better. Yeah.
Ready?
I mean,
Yeah.
here is a unusual question. Is Mount
Uh-huh.
Sinai participating in newer IVL Javelin trial?
No, not the javelin. We have another one here. Javelin is for, I thought javelin was peripheral, no? There's a peripheral.
No.
Yeah, yeah.
Coronary.
Javelin. No, coronary has not come yet. Peripheral. No. Whom? Okay. So javelin peripheral, yes. But right now we actually have two of them. One is the fracture trial of Bolt Medical. We are done not highest. Right now I'm second because we just did last week. By this evening we'll become number 1 in America by doing 10 cases. There
Okay,
are 8.
3O.
Yeah, here.
48, right?
Yep, 3 or 48.
Okay,
good.
That's a
So that one, the javelin is another one which is coming. Then
No,
Abbott also got the catheters. You know, the Bolt Medical fracture has been taken up by Boston Scientific. So Abbott has another catheter, IVL catheter. So every company is coming with the IVL catheter. And javelin is for our usual shockwave. The peripheral trials are ongoing here, but coronary we're not.
So Shockwave has a newer one, right?
Yeah, that's the javelin.
Then you have Abbott, then you have Boston.
Boston Scientific, and there are a few other companies. So many of them are coming with at least, I would say that by next year, the money spent, I say again, by the J&J for a $12 billion or $13 billion for the shockwave will become minuscule once you have a 4 or 5 competitor in the market. And that is what will happen by mid next year. Yeah.
You mean their value?
Value. Yep.
Yeah, almost the same is happening with the Impella also.
Impella,
as you
of
have
course.
mentioned
Yep.
all along.
Yeah. Same thing. Well, J&J had a lot of free money.
Okay, some.
Anu, just to
good.
give you a heads up towards you're reaching the
3.518.
stage where I'll ask you summarize the entire case. It's been proceeding so smoothly, but I bet you there was a lot of intellect and expertise which went into making all these decisions.
3.518.
We call it the AI, Anu intelligence. You see that? Go. 14.
14 or 16. Stent should be deployed at 14. Yeah.
Okay, down. What you want, a 3 to 528?
No, I think
not 18. Longer, no?
Okay.
Hold on.
23.
No.
Look for
Hold
23.
on. One second. Let's bring this back.
Yeah, good.
Okay, no need. Okay. Now take a picture. Ready? 3.5 SS.
Yeah, okay. That's why I said 3.5. 3.523 will be okay.
Have the IVUS ready again.
Yeah, so right now, do we start some presentation?
Yeah, go, done,
Okay.
done. We are
So
going to
while they're
IVUS and
putting
we are
the
done.
stent, no, do the stent, then IVUS. 23, yeah.
Done?
Okay, we can go to a presentation while they take the picture, put a proximal stent, and then come back with the IVUS. Okay, so this is where I left it with the appropriateness. So our if,
You mean we need
key
a balloon
interventional
pump?
trials, we
Balloon
presented
pump?
4 last month and another 4 this month. The Flash trial, River War trial, Reverse It, and Warrior trial. Then the focus review of the month, the study done from Mount Sinai, very complex with the bifurcate risk score to predict MACE. This is basically about 2,000 angiogram read by the team at Sinai under Dr. Keeney's leadership and come up with a score because everybody wants to know the which case of bifurcation we could get into trouble, short term or long term, and that is where it comes out, this publication is, and we'll talk about it. So Flash trial, what was the Flash trial? Flash trial was the fully automated QCA versus OCT guided PCI done in Korea. Very important. So basically knowing that artificial intelligence is coming quite a bit on the angiogram. So this basically was about 400 patients. And what they found, the primary endpoint was minimum stent area and the non-inferior. So primary endpoint was identical in the OCT guided versus AI QCA guided, as you can see here. Then the other important endpoints, stent expansion, under expansion, dissection, untreated reference vessel, they were all identical. Only difference was malapposition. So QCA, people have higher, patients have higher malapposition, 13.6 versus 5.6 in the OCT. And this was all done. There are OCT criteria, how the PCI should be done, except one group only have QCA, AI QCA, other one has OCT, and this is where we saw the difference. And that basically tells you that AI QC assisted PCI was as good as the OCT. Second was the Renover trial. That is the rivaroxaban versus warfarin in patient with left ventricular thrombus following MI. Because we know the left ventricular thrombus is a problem, happens in about 2.7% of MIs, and in the anterior wall happens almost 10%. So question comes, over the years has been shown that warfarin is a treatment for left ventricular thrombus, and that's why I was taught. There are some small reports about it. Direct DOACs have been used, but there was no big randomized trial have been of safety. So what they did is, in this 400 patient trial, rivaroxaban versus warfarin, and echo was done at 4 weeks and 12 weeks. So basically was, that question was that is rivaroxaban as good as warfarin or was associated with the more complications, and this was shown here. So basically what did we learn? At 4 weeks, the thrombus resolution was faster and better, favored rivaroxaban, but at 12 weeks, it was identical. So what we learned basically is that at rapid resolution of thrombus happened with the rivaroxaban, but at 12 weeks, they were identical. You say, okay, as long as it did not embolize. So what are the individual endpoints are here? So basically, all-cause mortality, ischemic stroke, major bleeding, all were identical, as you can see. Resolution of thrombus was faster in the rivaroxaban group, but at 12 weeks, both were identical. So I would say I was a little surprised. What I was surprised was basically, one is the bleeding. So I thought there will be lower bleeding in the NOAC group, but did not happen with rivaroxaban group. Secondly, I still felt that there will be more embolism, but will not. But ischemic stroke did have 3.5 versus 1.1 with a large number of cases would have made a difference. We do not know, but overall it is very satisfactory, and therefore they put it together as a summary that 4 weeks rivaroxaban is plus, at 12 weeks both are identical without having embolism in between. So that's a good message. Then third trial was reverse it. What is reverse? Remember, the ticagrelor is a very high concentration in the blood. So it binds to the reverse, it's an irreversible binding to the platelet, and therefore there is a lot of circulating ticagrelor. So patients start bleeding on ticagrelor, which is being used more and more in patients with MI, high risk PCI, and acute coronary syndrome, even medical management and some stroke patients also. So those patients, if they start bleeding, your platelet transfusion is not the answer. because there is so much free concentration of ticagrelor, you give platelet, they will bind to the platelet. So therefore, that was not the answer, and therefore the work is being done to find the antidote. And this antidote is bentracimab, basically have been done in the initial trials, and rapidly reversal agent. This is a intravenous monoclonal antibody, and what it does is basically binds to the to ticagrelor. So now once you have this complex now will basically washed out, and now platelet are free for the ADP receptor inhibition. So that basically is earlier data I have shown, giving this all this complex name, bentracimab, like apiximab. The bentracimab that does decrease the platelet aggregation very rapidly within few minutes, as shown in the study. And this was the patient who had either going for surgery or patients who were bleeding. So this was a single arm study of 150 patients, and basically showed that of course the patients were followed, but more importantly that platelet inhibition, as you can see right away, there's a dotted line with the PRU on the left side. Anything more than 180, the inhibition is platelet inhibition is like gone, and you can say very rapid inhibition of the platelet activity. So very effective drug, works within 10, starts working into 10 minutes and so, and safety concern, there's no safety concern, and they put it together as a trial summary. So at least we now have, once pending the FDA approval, we'll have the agent to reverse it's an antidote for ticagrelor. So that's a great news. The last one shown in the ACC was the Warrior trial, which is a woman's ischemia trial to reduce events in non-obstructive CAD. So we know that many of these women, particularly they continue to have chest pain, coronaries are good, either angiographically normal or ischemic ischemia. So ANOCA and INOCA, but what happens is they have high event rate and hospitalization. So therefore, there is actually whole guidelines in the European Society guidelines that how to manage these patients, doing a microvascular assessment and so. And we are starting at Sinai the microvascular series every other month with Joe Sweeney. So what they did basically is say, well, let's find out what happens with this treatment of this non-obstructive coronary artery disease in these patients who are ischemia by clinical symptoms or by the stress test, and this is basically INOCA patient. So this is a large trial, about 1,200 patients. This was pre-COVID. Then after at the COVID, there was a big issue about the enrollment. About half diagnosed by the Cath, half diagnosed by CTA, and they basically said, let's do two things. The patients who have non-ischemic, that either do intense medical therapy or do a usual care. So that was the goal was that maybe patients who have the microvascular disease will favor with the intense medical therapy, which was defined as high intensity statins, PCSK, ACE inhibitor, low dose aspirin. Now just want to say SGLT and other receptor were not, the blockers were not used in this particular study. What did they find? 5-year follow-up, exactly identical, usual care versus intensive medical therapy. So one of the reasons the criticism was that patients with their usual care gradually got better treatment and they more intensified. So at the end, the dosage of these individual drugs were almost similar between two strategies. So, but this was a negative trial which has been shown here. Look at the chest pain hospitalization in this group of patients. It's a big trouble. 80% were at least admitted one time. About 40% admitted more than 2 times. So key is that bleeding is very common. The chest pain admission is very common in these patients. So very, very important issue. As you can see here, other endpoints were not different. All were, so just to say that patients, irrespective of the intensive medical therapy or usual care, had the frequent hospitalization as shown here. And then of course there was some question where any treatment effect, and so there was nothing there. So this was a trial which was considered as a negative trial, and basically, but there is a lot of the sub-analysis, I would say comments in the ACC that don't count this as a negative trial because you still have to treat these patients who are INOCA or ANOCA two with the aggressive medical therapy. And yes, both were good. So it basically tells you that you, even usual care, you're doing a better treatment. Now, this is a little different than what we have. There is a trial called Cormica. Cormica trial was of the patient with a non-invasive CAD, non-obstructive CAD. They did a microvasculature studies and then changed the therapy. See that? Intervention group, cornea angiography versus control. And they followed these patients up to short-term outcome and 1 year outcome. And you can see there that invasive coronary angiography patients did better in terms of their improved angina, better quality of life, and subsequent outcomes at 1 year. So this one was, Cormica was a different trial. Was basically patients had an angiogram and then treatment was assigned. So they got a calcium blocker, some got beta blocker, and whatever needed, the whole protocol, just to say, once you do the microvascular assessment, guided therapy based on the Cormica, outcomes were better in the microvascular assessment trial. So, but it did not happen without microvascular, except that just by having a non-invasive CAD and chest pain, your medical therapy you can do, but the earlier group of medical therapy did not make any difference. So Anu, you want to show something now?
We're going IVUS someday.
Okay, you want to do it now?
Yeah.
Or we wait? Can I
No,
finish?
IVUS is going in. That's it, done.
Okay.
Then we're done.
So now so we can go to the next one, which is a
No, we are going IVUS.
Okay, so IVUS is going to be shown live. So you open the side branch?
Yeah, the RV branch was a large branch, but was occluded. Despite I was trying to avoid, the two stent overlap at that place, but for whatever reason we were occluded. I recrossed it, opened it with a 2O balloon. We post-dilated the stent, and now we have the IVUS ready.
But RV branch was, the overlap was not at the level of IV branch, was it?
No, it was not,
Check the
but
image.
then still
It's
we
already.
have some.
And our guide is out. Okay, start fullback. It's coming. Yeah, it's an edge. Good transition. Yeah, we're expanding stent. We did 3-5 post-dilatation. Yeah, I see the side branch. Come to the proximal. Nice, expanded. O2 lumen. Yep. Came into the guide.
You want to squeeze a little more proximally? Or?
What, 3-5 we went up to 20.
We did
What more you want?
No, but
Proximal, you tell us what's the MSA before we take out?
So like 8. Area-wise, it's good. Actually, the vessel size is like a 4 low. If you want, you can expand more. But area, MSA, yeah.
You want to go with 4O post?
Anyway, area is good because 8. But proximal part of the vessel is, yeah, like more than 4 low vessel.
Huh?
4O.
You want
let's see the
4O?
last angio. No.
Okay, take a picture.
Yeah, we have to see the picture now.
Oh, wait. Okay, good. Okay, ready?
But have you given a little nitro?
We gave.
To me, I think looks very, very good.
Back to the basis. We review IVUS
What
and
happened
make
to
a
the circ-
decision by the angiogram.
Huh? What did you say?
It's filling up the circumflex now. There's so much blood flow. The reverse.
It's going to the other side. Yeah.
Other side.
Yeah. I mean, based on MSA.
So Swati is she got a good breakfast today. Probably omelette. Look at that. Open up the circumflex.
Swati's birthday, so that's why she's full of energy. A year older now.
Yeah. Okay, I think this is done. We don't need to go lumen. Once you got more than 6.5 or 7, I think it's a good enough. There's no area less than that. Yeah.
No, let's ask Kiski. You happy?
No, yeah, of course, because MS is 8.0. It's
Okay.
much more than 5.5.
No, and
so.
stent is well opposed, though
Yeah,
there
yeah.
is a lot of plaque behind the stent.
No,
So you are going to show step by step. Let's go through the bifurcate risk score,
Yeah, finish your thing. Low mag.
which is done work at Mount Sinai. About 2,000 plus angiograms were analyzed by the CAS system, and 1,888 patients went for PCI, and then analyzed with the PCI or the bifurcation, true bifurcation, and they came up with by regression analysis, individual endpoints, 6 of them, lesion, and 5 patient characteristics: insulin dependent diabetes, low EF, non-STEMI, age more than 80, and non-white race. Angiogram, left main bifurcation, circ-OM bifurcation, multivessel lesions, side branch thrombus, side branch moderate to severe calcium, side branch lesion length more than 10. As you can see, Each were the independent predictor, and the points assigned is weighted based on the event rate at follow-up, and they came up with a score. The low risk score, quartiles, 4 of them, 0 to 3, 4 to 6, 7 to 9, and 10. And look at the MACE increase, exponential, 4.3, 5, 11, and 20. And the individual endpoints right there. Low risk, intermediate, or high risk, each point of the MACE, all-cause death, myocardial infarction, TVR, although no difference in stent thrombosis. So just to say, the simple bifurcate score can tell you who is going to get into more trouble. So what does that all mean? It's very simple, that you need to be more aggressive in those patients. These are the individual endpoint, as you can see, a follow-up of about 15 months, and these are the data shows. So nice figure, central figure of this bifurcate risk score to predict, and I'll ask Anu, the master mind on this publication. So what the input we have, but just to say, of the various risk scores which have been done in the past, that you now have another, the risk score which can predict outcome of the patient short and long term. Anu?
Yeah, so if you see, most of the time, it's always only angiographic risk score. So if you see angiographic risk score, we have that, but then we added the clinical risk score. So I think you have to combine both, which you always know. It is not just the angiographic, decision. When you see any angiogram, how to take care of the patient, you have to take care of the patient and risk factor modification after what we have seen. That is why this score is so important to understand. But more important is subsequently what we want to do based on this risk that we have predicted.
Yeah.
Anu, just staying here before Samin jumps in with the answer. Do you think in maybe less than 3 years, you probably will take an angiogram and there will be an AI prediction of the risk score?
Just hold on that. So very good. So let's go to the next slide, which is very important point which you said, and we'll ask Anu because she's working on that. So clearly the risk stratification, and that really was the crux of the editorial. Look at this one. So basically what they're saying is the personalized coronary intervention in terms of starting with the patient clinical characteristics, laboratory biomarkers, clinical and genetic profile, and then the lesion characteristics, but that makes our part, which was then the bifurcate, the lesion and part of the clinical, and then of course the other point in terms of the imaging and the CCTA, and then based on that artificial intelligence powered data and image processing comes up with the dynamic risk stratification of these patients and real-time procedural guidance and targeted pharmacotherapy. So question always comes, so yeah, you found out it's a very high-risk patient. So what does that mean? So well, that means that that patient need to be more strictly and aggressively followed. Keep LDL of 45, GLP receptors, ST, all those additional medical therapy which can be given to those patients should be done. So that basically is that patient with a high risk. So coming back to the point, this point of the AI generated, the risk profile, and they have very nice description that this is what the future will be in terms of subsequent acute procedural outcomes, and then optimizing cost effectiveness with reducing the risk of restenosis and adverse care, adverse outcomes, and this models they will be made which will incorporate the AI in there. So Anu, you want to answer that question?
Yeah, I'm going to show you the slide.
Yeah, so basically here, so we are already working on the angio quad AI that you can read the angiogram, automatic edge detection, and this is compared to manual QCA versus AI, and the whole report will come. The lesion length, lesion type, vessel size, and so, and more importantly, which is pertaining to our case, is basically in terms of the bifurcation, combining AI with bifurcation technique, and you can see here, based on the side branch diameter and with the automatic QCA of the bifurcation lesion, and that exactly was your question, and I'm glad that you came up with a question yourself without any prompt.
So this is what we are working on. So go back to the previous. So that previous what we have done, AngioQuant. Yeah. So this is already done. Okay, that where this software can be incorporated into your system, whatever system you have. Once the angiogram is done, you just have to click it, and then it will give you all the lesion length, diameter, percent diameter stenosis, and automatic lesion report will come. But more important, which we always, I mean, our the reason we wanted to do this is first we have to get analysis of angiography, and then how do we treat bifurcation, and that's where the next part is, which we are working on right now, that the same QCA is now going to automatic detection of bifurcation lesion. So once the angiogram is done, there is bifurcation lesion. Based on what we are now telling the model, that we are training the model, that if it's a true bifurcation or bifurcation with no side branch involvement, then we can give suggestion. All we can do is give a suggestion that this is the way this treatment can happen. So one is, like we said, the angiographic criteria. That's where this will come into equation. And I mean, the next, that's the first step. The future step is incorporating the clinical risk factors of the patient into this model. So this is where we are, and hopefully within the next few months we should have it ready, that the AI generated management of bifurcation lesions.
So Samir, you want to add on to your opinion on that? You are also AI master.
Exactly right. The only problem here is going to be that the first set of data which you'll have will not necessarily be accurate, because it is going to be based on a couple of thousand patients. But if you make it 100,000 patients, 2 million data, it's totally different. I'll give you an example. About 10 years ago, we started modeling
ECG.
as to what exactly, how do you predict air pollution? So you initially came out that it was the air quality index. Then we realized it was PM 2.5. And then as more data came in, this was done in Sao Paulo, we realized it had nothing to do with the air quality or the pollution. It was related to humidity. So once the cohort for AI becomes larger and larger, which is why I can tell you right up front today, I can tell you that unless you have numerous institutions pooling in data, the models will only provide you that particular benefit. But it's on the right path. I've been talking to Dr. Kinney about this for the last 10 years, that in future, it's all going to be AI based. You'll take a single angiogram and that'll guide you as to what kind of a guide wire you should use, what guiding catheter, so exactly on the right track.
Okay, let me just correct both of you that, once upon a time you needed millions of data set. Currently, the computer scientists are so smart, okay, that entire angioquant was done with 800 angiograms. So that is what's called a supervised, training, where they're training, whereas you unsupervised. So in a supervised training set, and depends on most of these computer scientists who are now doing PhD in AI, you just need a few data set that is 100% accurate, and that's how you come up with. You do not need millions and millions of data anymore. Those days are done.
We'll have to wait for that. You have to realize that the fact that they are already using the supervised model, they have already gone through a lot. I mean, they have already reached a distinction there, but all steps in the right direction. Samin, there is a question by
let's also tell you no. Video-based work and angiogram-based work, it's not there yet. Okay, Sina is the first one to be doing this kind of work.
Yeah,
excellent. And I know you're on the right path. Samin, question: any ongoing trial of DOAC for prosthetic mechanical valves?
Yeah, so I think the last trial, which was done about 1.5 years ago, failed. I don't think they're going to go with the prosthetic valve anymore. They lost all the money. So it looks like prosthetic valve remains in warfarin. Everything else, the DOAC and NOACs have come up. And coming back to the point, what I really wish and will see, hopefully, that this question always comes. This bifurcation angle, the size and the length, where the lesion is with the Medina type. So what should be your strategy? The biggest question comes what? DK crush, mini crush, culotte, tap. So we feel that by this first is maybe this AI driven or AI based QC analysis of the bifurcation tell us that what is the preferred bifurcation strategy. And then of course you go with the various balloon wires and so. Then second is the bifurcate score telling you that, yeah, this is a very complex lesion and this is the score is very high. This guy into trouble. Do everything possible in this case. Your SGLT, GLP, all the receptor blocker, whatever you best you can do, inclisiran, PCSK, whatever need to be done should be used on those patients. So therefore, I think the field will continue to evolve and a lot will come with the Anu's kind of, the analysis being done at Sinai. So let me just sum it up now. The outcome after AI-based QCA guided versus OCT guided PCI, one thumb up. Rivaroxaban versus warfarin for management LV thrombus, two thumbs up. Because this is the first randomized trial, 2-to-1 ratio, about 400 patients showed rivaroxaban as good as, rather better, in resolution of thrombus without any embolism or bleeding. Third, new recombinant IgG antibody, ticagrelor antidote, we finally have it. And then intensive medical therapy versus usual care in INOCA or ANOCA, both, which is ischemic, non-obstructive CAD or angina, non-obstructive CAD at 5 years with two thumbs down. So as such, the way it was done. But I think one of the biggest thing was there was no input of the microvasculature in there. So Cormica trial, the example, there are a few others also. So you need to base, once you are working on the INOCA and ANOCA, you need to guide your therapy based on the microvascular assessment because that's very important. Who gets vasodilator, who gets beta blockers and so. So a novel simple risk score with a 6 angiography and 5 clinical, very simple, predicting MACE, and therefore it can guide patient tailored treatment strategies for short and long term with resource utilization. Now, what we need is a prospective study utilizing bifurcated score in management of coronary bifurcation lesion is warranted. So we have data now, and this put it into the AI technique or without, do a prospective study will be useful. Now, come back to 3 questions. The FLEX trial comparing AI-based QCA versus OCT-guided PC at 6 months showed the following, except similar MACE rate between 2 strategies, similar MSA between 2 strategies, overall stent expansion, stent maloposition, and dissection. So clearly was the D. The stent maloposition was higher in the QCA-based versus OCT-based. Second, the trial of Rivavar comparing warfarin versus rivaroxaban regime showed at a 12-week trial, similar mortality rate between 2 groups, similar stroke rates between 2 groups, similar major bleeding rates between 2 groups, similar LV thrombus resolution at 12th week between 2 groups, and similar LV thrombus resolution at 4th week between 2 groups. Remember I said the 4th week resolution was faster with the rivaroxaban group compared to warfarin group. So that's the wrong answer. Lastly, the following are the independent components of the novel bifurcated risk score predicting follow-up MACE at 1 year after bifurcation PCI, except left main bifurcation, COPD, side branch moderate to severe calcification, insulin dependent diabetes, and age more than 80. Remember, COPD is not the independent component. So with that note, now those who need to have a CME credit, they can go on to the webinar and evaluation credit. They have to fill up some minimum forms and then download the certificate. And with that, we complete the presentation for today.
Samin,
Yeah.
a quick, I have a few follow-up questions, and then of course, I look forward to Dr. Kinney providing a summary of the case and the tips and tricks which people should have learned. So first of all, Anu, congratulations for the, what I called it here is the BRS, the bifurcation risk score. You could even call it a BSc, like a BSc in engineering bifurcation score. But truly wonderful, and I think it'll come in extremely handy to people. Samin, a question first of all, bentrasimab, does it affect prasugrel?
No, it is only for ticagrelor. It's a specific antibody of the complex of the ticagrelor with the ADP receptor. Yeah.
Which was my understanding also, and I think we've not had a chance here to thank Dr. Deepak Bhatt, This has been truly his endeavor, and Deepak, if whenever you listen, congratulations, a step forward in the management of ADP blockers. Anu, summary of the case, your
Yes.
entire approach, believe me, you made it look so simple, and I tell you, there was a lot more critical thinking and decision making there.
Yeah. So let's go back to this. So I think this was a picture, right? Okay, here. So this is where I think we started when we said which septal.
Okay,
This is
show the angiogram now. Yeah, okay.
Yeah, so you can see that, right? The large septal that is fanning, and then you, how do I show? Second branch of that large septal. That's where you see it is connected to the PDA. You're able to appreciate that?
There's a laser in there?
Yeah.
No? Pointer.
So the
Pointer
first
with a laser.
wire, same, you need a 150 centimeter micro catheter. So we took a Corsair 150. Now anybody wants to use Turnpike or whatever they have, that's okay. Now why Corsair or not fine cross? Because you need something that you're able to, you know, torque turn, so you can navigate through the septal. And usually the most difficult part is the septal at the lower part of the septum, because there it's making a acute turn. Septal of the LAD is, then you have a meeting with the septal of the RCA. That acute turn, always you have issues. That's exactly we also showed also. So what will be the first wire of choice? Fielder, regular fielder FC, which is again you know, low tip load. Some people go with that wire, and once you are in the right septal, so we actually took just fielder, and with the fielder itself, you know, the curve has to be very small, and we were able to get into the second septal, second branch, and then we see that this is the fielder wire. You see it, I pulled back from it went into the first branch, then you come down. Now keep rotating. Now you're going into the second. You see that? And you have to be very gentle. The wire has to find its own place to go. Don't be aggressive. Now you see that? That means that septal connection is very good. Now we are entering in the RCA. You saw that?
Yep.
Okay, so let play again. So that was in the first branch. We pulled back, went into the second branch, the same fielder. That's the second branch. Gentle movements, back forth, you know, with these fingers, micro movements. Okay, and then we went into the RC. So now after that, now if at any level, if you had any issues, that's the time you want to change it to the softer tip wire with lower tip load, which could be again fielder FC SUO wire. So then what you will do is move the Corsair after this. We don't have that.
That to me was the real case.
Yeah, I think that we did not save. So then we were able to corkscrew the whole Corsair. And once you are in the RCA, you see that in the distal RCA, we are now in the distal RCA, you use the same wire, and you see, because you know the distal cap is softer. So if the same fielder can go through, we can, but we did not keep that. We could not, we change it. Now here people may have various, wire choice. They may want to use Pilot. They may want to use Gaia, but I like a good old Miracle. So Miracle 6. So you needed something. What happened is all these other wires were getting into that RV branch. So you needed a stiffer wire to pierce that distal cap, then go through that true CTO. You see that? And when you are there, you just make sure you get into the lumen. We were never subintimal here, and we are able to get into the RCA. Now after this,
that was amazing, Anu. You didn't realize it as you were explaining it. Your fingers were torquing to us on the. We watched you.
Okay, now when you're here, this is another challenging part. Normally, to getting into the guide is not easy. So that is why the curve of the Miracle is very good. So if you are using any other wire with a smaller curve, you know how we say CTO, the curve has to be very short. So if you had used any other wire and your curve was really short, then getting into this guide. So you have the entire RCA, then you have guide that is there. So you have to be coaxial to get in, to get into the guide. Not easy. So you know the guide is here. The wire has to come and get into the guide in the coaxial way. So we showed that. You see that now? We are getting into the guide. I think you can see last time when we did it, right, we struggled a lot to get into the left guide of the left main, the last live case. So when you are there, now what you need to do is anchor this wire, because getting this Corsair through the CTO will not be easy. You already see the guide of the left side getting sucked into the left main. So to avoid that, what we did was you take a 2O balloon. You can see that, right? So you see the 2O balloon. So the 2O balloon is in the RCA. You go just inside the guide, anchor the wire. And after that, once the wire is anchored, again, nice movement, back forward movement, corkscrew movement, and get the Corsair through the CTO into the guide. So after that, you see that, then you do externalization, which I think we can only watch on the video. When you do externalization, that means once the Corsair is in the guide, then you remove your you know, whatever we use of Miracle, take it out, and 330 wire, whether it is RG3, RG330, you go through the left side and come out of the right side. Now at that point, you know, what we did last time, retrograde, and what we did this time was different. Last time what we did was, as soon as we came out of the contralateral, we went with a fine cross on the from the contralateral, and then we removed that wire. But here what happened is we dilated on that wire to show a different step. We dilated on this the RG3 wire. We showed that the flow is very good. Then you can go side by side with any 300 wire workhorse wire, and you know, you're finished. But the key step is, how will you remove this 330 wire without what we call is the cheese grating effect, where when you remove it, the septal, where I said, you know, the septal of the LED and the septal of the RCA meet, and when you're taking this wire, no matter how gentle you are, there's a risk that you can perforate that septal area, and hematoma, you know, perforation, pericardial effusion can happen just if you not do that step right. That is why we went back with the fine cross and we showed that step, which is, you see that? Now you see it very well?
Yep.
And that the fine cross is there, then you have Corsair there. So you have the two microcatheters. You see that the two microcatheters, which two microcatheters are talking to each other. You see that?
Yep.
Yeah. So when they are close to each other, it's like there is a you know, cover, and then you can just remove your 300 wire through that. And while doing, look at where the guide is on the left side. Despite that, at one time the guide got sucked in. So keep watching the guide as you're doing that step. You can see it coming out, wire, and after that you remove the guide. Make sure your left system is very good, which is very good, and pay attention to that septal, because that septal can have a risk of you know, perforation or anything. No leak from there. And after that we we dilate. This was IVUS we did. Yeah, then we dilated and stents. That's it. Okay, now I pay a lot of respect to the RV branch. Look at that RV branch, despite okay, let me go back. See that where we placed the stent. See, we were across the RV branch, means we did not overlap at that level. Despite that, we lost that RV branch. You see that? So that's not good. It could be also, remember last time when the antigrade, when they were trying, maybe there was a little bit of dissection, which probably caused. So once we lose that RV branch, we went with the fielder wire. I may have that. So you go with the fielder wire. Yeah, see this is a fielder wire going into the RV branch. Then we dilated it with the 2O balloon.
You make it easy. It must have been tricky getting the wire there into the RV branch.
But this is the fluorosave. Yeah, okay.
Excellent.
Then we did the PTCA, and of course we have the final IVUS. All that we did live, and this is the final picture.
No, outstanding review, and there is a universal appreciation of your superb skills here. Samin, there's one quick follow-up question, then an excellent comment by one of our viewers. The question is that you've been advocating 5 milligram prasugrel for less than 100 kilogram. Is that still the case? And have you published the data for half dose patients?
Oh yeah, absolutely.
People listen to you very carefully.
Yes. So we actually the various antiplatelet therapy in stable and acute coronary syndrome. We have JAK intervention paper, and we put it with this strategy, and we said that about 47% of cases got 5 milligram, and now some cases we do give based on multiple stents, and so you want to give it for 1 month of 10 milligram, but 5 milligram is the routine for less than 100 kilo, or stents are less than 3. If there are 3 or more stents, then we will still give 10 milligram for 3 or 6 months. But by and large, majority of cases will get loading dose of 60 milligram and 5 milligram once the 1 or 2 stents and weight is less than 100 kilo. And there is a publication, AJC publication, there is a Euro intervention publication, more important, JAK intervention paper, where they really wanted to have the data that what happens to the 5 milligram. And we found by giving 5 milligram, there has been no effect, absolutely no effect on thrombosis, 0, and there is a lower bleeding, tended towards the lower bleeding. So that basically the reason is 10 milligram is a very toxic dose, in my opinion. And you know that in Japan, they use 3.5 milligram. We are 5. Japan, they use 3.5. So clearly, many of the trials they have used 3.5 milligram of prasugrel because it's just 10, even 5 is. I mean, definitely the 10 is way too much for majority of the patient. But underweight, low weight patient, 5 or 3.5 milligram is good enough.
Enormous relevance to that, Samin. This is ending the case today so appropriately. I'm quoting exactly Saurabh Agustam. Take home message slide and questions is the best teaching of Samin sir. Thank you to the team. That is something which we have kind of noticed, but he's observed it beautifully. Samin, a final word on your upcoming course.
Yeah, so our CCC symposium on June 13th. And of course the nurse tech and fellows course on 12th. I actually have a special MCS course on 11th. So it's a good activity 11th, 12th and 13th, but most important our 13th CC symposium where we'll show 11, 12 live cases of this kind in the total 10, 12 hour window period, and of course a lot of lectures and hot debates will be shown. So we really invite everyone to be part of it, those who are around. Please come join, and then there is a boat ride on Friday evening. We'll take a 3 hours tour of that. Yeah. Huh? What? Tell me what? Yeah, so another point which we started was the 1 week which remained empty. We have one structural, we have one coronary, we have one peripheral. So the 4th one, which could be the first week, we divided now. Actually, we started already the imaging, IVUS or OCT, and microvascular, because there's a lot of demand or understanding about the microvascular. So Anu did the IVUS, the first CCC live imaging case webcast was done last month. This month will be the microvascular. Next month will be the OCT or IVUS. So we'll continue alternate. So goal is more directed in those cases. Of course, PCI will be done. or some cases microvascular, no PCI will be done. But more important is the discussion on the key point. And imaging actually was very big. We actually, within 24 hours, we have a 1300 hits. Did it increase further, Keski? There were like 1300 on day one. Yeah, so live cases, whatever, 70, 80, but 1300 hits on that. Imaging CCC live was fantastic.
Samin, absolutely very relevant topics. I want to thank the audience for keeping it very interactive, and we'll see you on June the 17th for the next session.
Beautiful.